Hello, and welcome to Management of Sedative, Hypnotic, and Stimulant Use Disorders. My name is Kate Marshall. So to start with, I have no financial relationships to disclose, no conflicts of interest. The opinions and guidance are my own and don't represent those of any particular organization or entity, and the cases have been modified and fictitious names used. So today we're going to spend some time on two types of substances, sedative hypnotics and stimulants. First off, we're going to talk about current trends in the misuse of sedative hypnotics. We'll talk about some medical complications of sedative hypnotic use, as well as how to manage sedative hypnotic disorder and withdrawal. And then we'll do it all again for stimulants. But before we get started, I want to do a brief review of some critical concepts in substance use disorders care. As you remember, substance use disorders develop when a brain that's been made vulnerable by heredity, stress, trauma, or being in a crucial period of development is then repeatedly exposed to a substance that produces significant reward. The brain then encodes the substance as necessary to survival, and behavior changes to reflect that. Between 10 and 20% of the population has an active substance use disorder, and that's not including tobacco. Substance use disorders are chronic. They're relapsing, but they are extremely treatable. And finally, using appropriate language in care, such as avoiding addict, abuser, dirty, and other morally weighted terms, and instead using clinical language that is non-judgmental, improves the quality of care for our patients and helps them heal. So let's start with a case. This is Sarah. She's a 28-year-old woman with a past medical history of anxiety who presents with a seizure after attempting to discontinue illicit benzodiazepines. On admission, her heart rate is 105 beats per minute, blood pressure 140/102, respiratory rate 24, and temperature 37 degrees Celsius. In the ED, she gets some ondansetron and a milligram of lorazepam. A CT head shows no acute abnormality, and a urine drug test in the emergency department is positive for benzodiazepines only. Checking the physician drug monitoring program shows intermittent prescriptions for short courses of clonazepam, with the last prescription about 6 months ago. So she's admitted to the inpatient service for withdrawal management. You talk to her and learn that she has a long history of anxiety and insomnia, and was previously prescribed clonazepam by her primary care provider, but was cut off when a urine drug screen showed oxycodone that wasn't prescribed to her. She says she had actually been trying to cut back on the clonazepam because she often ran out early, but was so uncomfortable while trying to reduce her use that she accepted the offer of a few oxycodone pills from a friend to take the edge off. Her provider warned her that using opioids and benzodiazepines together was unsafe, and declined to renew the clonazepam prescription. Since then, she's been buying Xanax from the same friend and had actually escalated her use to up to about 10 Xanax bars a day to stave off her anxiety, her insomnia, and withdrawal. She reports that she just wants to be off this stuff once and for all. She was again attempting to taper at home, but had a seizure 6 hours after her last dose. You diagnose her with severe sedative hypnotic use disorder, and as you put the diagnosis in Epic, you wonder, what is a sedative hypnotic? So, sedative hypnotics are made up of benzodiazepines, such as midazolam, lorazepam, and chlordiazepoxide, among many others, as well as barbiturates, such as thiopental and phenobarbital, plus some other miscellaneous drugs, Z-drugs, carbamates, ramelteon, and chloral hydrate. The commonality between these is that they all create calming or sedative, as well as hypnotic effects, so hypnosis meaning aiding with sleep. And all except those last two, the ramelteon and chloral hydrate, do so by interacting with GABA receptors. In contrast, gabapentin and pregabalin facilitate GABA transmission, but don't actually directly interact with the GABA receptor and aren't technically sedative hypnotics. As you remember, Sarah is using about 10 illicit Xanax bars a day and had a withdrawal seizure. She reports she does not use any other substances, including cocaine, methamphetamine, hallucinogens, or nicotine, and is clear that she hasn't used any opioids, prescribed or otherwise, in several months. She says she does sometimes drink alcohol, up to 4 standard drinks at a time on weekend evenings. So my next question for you is, which of the following is least likely to seriously harm Sarah given her current pattern of use? Is it benzodiazepine withdrawal, accidental overdose on benzodiazepines alone, contamination of her illicit benzodiazepine supply with fentanyl, or her use of alcohol? Which is the least likely to harm her? So I would actually say that overdose on benzodiazepines alone is least likely to harm her. Let's talk some more about why that is. So I'm going to talk for a moment about benzodiazepines in particular, since these are probably the most commonly used sedative hypnotics you'll encounter in clinical practice. They came into medical use in the 1960s, and by the 70s had largely replaced barbiturates owing to their superior safety profile. They're much less likely to cause respiratory depression than the older drugs. Their intended uses are as an anxiolytic or sleep aid, as an anesthesia adjunct, to treat or prevent seizures, including preventing seizures in alcohol withdrawal due to cross-tolerance with the GABA effects of alcohol. By the 1980s, though, the risk of dependence on benzodiazepines became apparent. In fact, benzodiazepines were the subject of the largest ever class action lawsuit filed in the United Kingdom around misrepresentation of the risk for dependence. No similar litigation, however, has been seen in the United States. In the United States, we've continued to see high rates of prescribing, especially in primary care. Between 2003 and 2015, psychiatry rates of benzodiazepine prescribing stayed steady, while primary care prescribing rates doubled. As you can see here, benzodiazepines are also increasingly prescribed to older adults. And as is reflected in the number of continuing versus new prescriptions, you can also see that they are often prescribed chronically, although it's not recommended. It should be noted that benzodiazepines are extremely effective, and that the majority of people who use benzodiazepines use them as indicated. Fewer than 20% who had a prescription misused them even once, and according to the NIH, even those who use them for euphoria or without a prescription usually don't develop a use disorder. And they are superior to barbiturates when it comes to safety. When benzodiazepines are used alone, no lethal dose has been established. But they are frequently co-prescribed with other sedating medications like opioids or used with alcohol, which does carry a high risk of oversedation and even lethal overdose in combination. As you can see here, benzodiazepines are increasingly present in multi-drug overdoses. But the safety of non-prescribed benzodiazepines is also a significant concern. The high demand for benzodiazepines, especially brand name Xanax, has led illicit manufacturers to create large numbers of counterfeit or so-called pressed pills that may look like Xanax, but are not made by any pharmaceutical company. In fact, pressed Xanax bars often don't contain any alprazolam, but instead may contain designer benzodiazepines like atizolam, clonazepam, or flubarmazolam, or may even be contaminated with other potentially lethal substances such as fentanyl. As you can see by the comparison in this image, the authentic Xanax is on the right and the pressed Xanax is on the left. It could be hard to tell the difference. For patients, this is a significant concern. It's also worth talking about other adverse effects. The use of benzodiazepines increases the risk for falls, especially in the elderly. As well as other accidents, benzodiazepine use is associated with a 60 to 80% increased risk of motor vehicle accident, with the highest risk in the first 4 weeks of use. Another major concern is impairment of restorative sleep. While short-term use for insomnia decreases time to fall asleep and increases total sleep time and quality by patients' reports, chronic high-dose use affects the microstructure of slow-wave sleep and may reduce the time spent in the most restorative sleep stages, which in turn reinforces the patient's need for help with sleep since they may become more symptomatic over time and not less. At high doses, benzodiazepines can cause anterograde amnesia, dissociation, and blackouts. And of course, there's a risk of dependence, tolerance, and withdrawal. So let's get back to Sarah. She's already experienced a seizure while trying to stop her benzodiazepine use. As her provider, you contemplate the options available to you to help someone discontinue their benzodiazepine use. So, which of the following are accepted methods for benzodiazepine discontinuation? Could you use a letter telling the patient to cut back slowly, a planned outpatient taper of 10% per week, substitution with phenobarbital or a long-acting benzodiazepine, then a rapid taper, or substitution with an anticonvulsant like carbamazepine? What do you think? So the one that's not appropriate here is just switching to an anticonvulsant. The first two really only work if you have someone with dependence on prescribed benzodiazepines or who's going to be really reliable about taking your advice. Studies show that about 50% of patients who received a letter advising them to quit gradually did so and maintained abstinence for 2 years of follow-up. So surprisingly, that might actually be effective. The most common approach is for the physician to guide tapering by about 10% a week in the outpatient setting, slowing down for the last 25% of the taper. With illicit use, that's not usually feasible, and there's a risk of overdose and death if non-prescribed benzodiazepines are used. These folks really need inpatient management for a rapid taper, either at a detox facility or in the hospital. You switch to phenobarbital or a long-acting benzodiazepine, then taper by 20 to 30% a day at first, then 10% a day for the second half of the taper. And many programs also prescribe a several-week taper of an anticonvulsant, like carbamazepine or valproic acid, to mitigate the risk of seizure after discharge. So Sarah was started on CWA-triggered lorazepam, followed by scheduled decreases in the daily dose over 8 days. She was also started on valproic acid with a planned 4-week taper. However, on hospital day 4, she reported that she was having awful anxiety and panic and was just not sleeping at all. So my question for you is, why does she have these symptoms? Do you think it's recurrence of her prior anxiety and insomnia? Is it rebound anxiety and insomnia? Is it pseudo-withdrawal, true withdrawal, or could it be post-acute withdrawal? More than one of these might be correct. What do you think? So this really brings up the question of withdrawal syndromes, which can apply to many different types of substances, but are often particularly bothersome when patients discontinue sedative hypnotics. So let's review 5 types of discontinuation syndromes. First of all, there's recurrence. This is the reemergence of original symptoms after cessation, and then it persists after acute withdrawal. Rebound is the transient emergence of worse symptoms during the cessation period, so worse than they were before you ever took the sedative hypnotic. Pseudo-withdrawal is an interesting phenomenon where symptoms emerge prior to a taper or with a placebo taper. For instance, the patient may think their dose is being reduced and be uncomfortable when in fact the dose has been kept exactly the same. True withdrawal is the acute physical or neuropsychiatric symptoms due to abrupt taper or cessation. And post-acute withdrawal is waxing and waning symptoms persisting weeks to months after cessation. As you think about these, it's important to note that symptom recurrence and post-acute withdrawal are your biggest risk factors for your patient returning to use, because they can be the most uncomfortable and bothersome, and the patient may feel like they're just never going to get better, leading them to return to use of the substance. So in Sarah's case, this could definitely be recurrence of her prior anxiety and insomnia, and if it's even more severe than it was before she took benzodiazepines, it could be rebound. This is not pseudo-withdrawal because we are actually reducing her dose. It could be true withdrawal because anxiety and panic and insomnia are potential symptoms of withdrawal from benzodiazepines. It's not post-acute withdrawal because of the timing. She's not through her acute withdrawal period yet, so she can't have post-acute withdrawal now. So in order to reduce Sarah's risk of return to use of benzodiazepines, you start her on an SSRI to help with her chronic anxiety. You anticipate she will have symptoms while you wait for that to take effect, so you supplement with as-needed hydroxyzine at discharge. And because you know that substance use disorder is a chronic, relapsing disease, you provide a naloxone rescue kit on discharge, as well as information about the risk of purchased benzodiazepines potentially being contaminated with fentanyl. You tell her that her symptoms will continue to improve over time, but in the meantime, encourage extra support with an intensive outpatient program to help her manage the recurrence of her anxiety and insomnia, and let her know that relapse prevention planning will be important in navigating the inevitable triggers for return to use she'll encounter over the next few weeks and months. A few weeks later, you receive a message from Sarah letting you know that she is now at 30 days since her last benzodiazepine use, and that while life isn't easy without them, she's hopeful for her future. Okay, it's time for us to move on to stimulant use disorders. This is Sam. He's a 32-year-old man with a past medical history of smoked methamphetamine use, who presented with bilateral leg swelling and is admitted for new-onset heart failure with reduced ejection fraction. Diuresis is initiated on admission and cardiology is consulted. When you meet him, you ask for clarification about his methamphetamine use. He says, "I never did anything until 5 years ago, man." He says he actually began using prescription stimulants that he got from his younger brother while working in a warehouse about 5 years ago. He could barely function toward the end of a 12-hour shift and needed something to keep him going. Eventually, his brother refused to give him any more of his medication, and Sam learned from another warehouse worker about a source for methamphetamine. He switched to smoking methamphetamine about 3 years ago. When you ask about other substances, he says he smokes about a pack a day of cigarettes and is trying to cut back, but says it's hard. At work, you don't get a smoke break if you don't smoke, so everybody smokes. So before we continue with Sam, let's talk a bit about stimulants in general so we can get a better sense of what's going on with him. Stimulants encompass a wide variety of substances. The commonality is that the substance increases signaling in the central nervous system, typically causing sympathomimetic effects. So let's review some stimulants that may come readily to mind and some you might not immediately think of. When we think about stimulants that are either legal or prescribed, we have caffeine, of course, which is the most commonly used psychoactive substance worldwide, and also the most commonly used stimulant. In the United States, its use is regulated by the FDA, not the DEA. Then there are Schedule II drugs like amphetamine and methylphenidate that are used to treat ADHD. Cocaine is actually also on Schedule II and is sometimes used in ENT procedures as a local anesthetic. There are a few other stimulant medications like modafinil, which is Schedule IV. Nicotine and kratom both have stimulant effects, but are not purely stimulants. Nicotine increases signaling in the brain overall by binding to those nicotinic acetylcholine receptors. Kratom causes dopamine and norepinephrine release in addition to its opioid properties, and it's not currently regulated in the United States. Cocaine and methamphetamine are widely trafficked in the illicit drug market, along with other stimulant compounds without any currently accepted medical use, including MDMA, also known as ecstasy, cot leaves, and bath salts, which are synthetic cathinone compounds. As I mentioned, stimulant use is extremely common. About 80% of U.S. adults consume caffeine on a daily basis. As far as prescription stimulants go, about 6.6% of U.S. adults used a prescribed stimulant of some kind in the last year. Of those, about a third misused that stimulant at least once. Only 3% of those with misuse had a prescription stimulant use disorder. When we look at the reasons why people misuse their prescription stimulants, the most common reasons were kind of benign. The vast majority used it to concentrate or study, and only a few to get high or experiment. Misuse was actually most common in people under the age of 50 who had another substance use disorder and who had either very low or very high income. A little less than 1% of the adult population of the United States has used methamphetamine in the last year, the highest numbers being in Oregon, where a little over 2% have. Part of the reason for that is the new meth being imported from large labs in Mexico. New meth is fully synthetic, so you don't need the ephedra plant or ephedrine to make it. But it turns out that methamphetamine produced this way is much more likely to cause psychosis or hallucinations than methamphetamine from naturally derived precursors. And you can see the effect of methamphetamine on the West Coast in particular. Here's a map of meth-associated heart failure hospitalizations in the U.S. We're at the epicenter, and these increase year over year. And these patients are an average of 25 years younger than other patients hospitalized with heart failure. Now, with over 80% of U.S. adults using a stimulant of some kind, I think it's worth asking ourselves about the potential benefits and drawbacks of stimulant use. What do you think? Why might a stimulant be appealing? Why might it be harmful? When we talk about potential benefits of stimulants, alertness is one that comes to mind. And in particular, in unhoused populations, sleep can be a vulnerable state, leading to stimulants as a necessary tool for survival. Another reason might be concentration, often to help with study or job performance. For similar reasons, the energy provided by stimulants might be critical in somebody's function. Surprisingly, stimulants can actually affect pain relief, or at least make pain easier to bear. Many people find methamphetamine relieves chronic pain quite effectively. And of course, with the stimulation of the sympathetic nervous system and the release of dopamine, there can be euphoria and a very pleasurable rush. When we talk about adverse effects, we think, of course, of withdrawal, whether that be headache, profound depression, somnolence, anhedonia. Psychosis is a significant concern, especially with the methamphetamine that I mentioned, and in that case, it can be temporary or permanent. With any substance that causes elevated heart rate and blood pressure, you have concern for arrhythmias and myocardial infarctions. Pulmonary hypertension is another known and potentially very serious complication of chronic stimulant use, and we see this more and more lately, especially with methamphetamine. And of course, heart failure, which is a growing concern, as you saw on that map. So let's get back to Sam and think a little bit more about the effects he's seeing from his use of methamphetamine. So in the hospital, at first he's doing well. He's getting his assessment from cardiology and seeing improvements in his swelling and shortness of breath with ongoing diuresis. But then on hospital day 2, you get a page from his nurse regarding somnolence that is becoming concerning to her. You head over to assess him and learn that his heart rate is 68, blood pressure 118/70, respiratory rate 12, and temperature 36.2 degrees Celsius. He does rouse to voice, and he is oriented but irritable. His pupils are 4 millimeters and reactive bilaterally. His skin is warm and dry. A rapid urine drug test is positive for methamphetamine and opiates. And you note that he's been getting as-needed hydromorphone for leg pain, but his nurse is concerned that he may have taken something not prescribed to him, and that's the reason he's so sleepy. So let's take a look at this clinical picture for a moment and think about what might be going on with him. What do you think? Could this be an opioid overdose? Could it be in-hospital use of methamphetamine? Could he be in methamphetamine withdrawal? Or do you think this is acute decompensation of his heart failure? To me, this looks like stimulant withdrawal. It can be easy to confuse with opioid excess, though. In this case, the pupils aren't pinpoint, so I have low suspicion for opioids as the cause of his somnolence. And with these vitals and his warm and dry skin, I'm less worried his somnolence is due to his heart. As for in-hospital use of methamphetamine, we'd probably be seeing a higher heart rate and blood pressure if that were the case. And when you talk to Sam about his symptoms, he reports that he is extremely depressed and tired. And even though he knows his heart problem is likely related to his stimulant use, he is having strong cravings for methamphetamine. He asks you how he can quit once and for all. He's tried several times in the past, but ultimately becomes so depressed and tired that he ends up going back to methamphetamine so he doesn't lose his job. Let's talk for a moment about the most effective treatments we have for stimulant use disorder. It turns out that for stimulants, behavioral treatment is absolutely the mainstay and has the best evidence for efficacy. First off, we have motivational interviewing, which you can do yourself in the hospital or clinic and which helps the patient set and clarify their own goals. Contingency management is one of the most promising newer therapies. Essentially, the treatment uses competing rewards to try to rewire the brain to prefer not using the stimulant rather than using it. It's also flexible across treatment settings and can even be done by a patient on their own through an app. Some insurance providers are starting to provide reimbursement for this type of treatment, and in other settings, grants may cover the rewards offered. We have community reinforcement therapy, in which the patient analyzes and reframes the role of the substance in their emotional, social, family, and work life, and works to identify triggers that might lead them to return to use even when they don't want to. Cognitive behavioral therapy is another important and well-studied treatment. This is one where the patient cultivates awareness and even acceptance of thoughts and urges they might have around the substance, and it's similarly flexible and can be delivered online or via an app as well as by a provider. Finally, we come to medications. Now, sadly, there are no FDA-approved medications for this disorder, but a few show promise. Often, if someone has another indication for one of these medications, we'll have a fairly low threshold to start one. In one study, mirtazapine was found to reduce the use of methamphetamine in men who have sex with men over 24 weeks of treatment plus 12 weeks further follow-up when added to behavioral treatment, and that's compared to placebo. Bupropion alone hasn't shown any effect, but when used at high doses, around 450 milligrams a day, and combined with long-acting injectable naltrexone, there is at least one promising trial. Several studies have shown topiramate to be superior to placebo over at least 12 weeks of treatment. In one randomized double-blind placebo-controlled study, patients randomized to topiramate were over 3 times more likely to have cocaine-negative urine drug screens over 12 weeks. So back to Sam. He was referred to residential treatment for behavioral counseling, but was unable to stay more than a few days due to a family emergency. However, he reported that his heart condition was a major motivator for stopping methamphetamine, and 3 months later he reported he had been completely abstinent and was found to have some recovery of his ejection fraction. Which brings us to our conclusion. In sum, misuse of prescription sedative-hypnotics and stimulants is relatively rare. However, illicit use of these substances is increasing. Sedative-hypnotics can be discontinued by slow or rapid taper, but always undertake relapse prevention planning to prevent a return to use. Stimulant use disorder is a growing cause of hospitalization and heart failure. But behavioral treatment for stimulant use disorder is first line, and some medications show promise. Thank you.